Hello everyone, welcome to my channel. It is Nursing Ed KJS Keaton here with another video. And in today's lesson, we're going to look at a case study of a patient who has pulmonary embolism. We're going to delve into the details of this case, discuss the symptoms, diagnostic processes, and most importantly, nursing interventions, which would all play an important role in the management of patients who present with signs and symptoms of pulmonary embolism. We're going to jump into the heart of patient care with a real life scenario. So let's begin, and if you haven't already subscribed, hit that notification bell so you never miss out on our insightful discussions and case studies. So let's get started. So George is a 74-year-old male who initially presented to the emergency department post-op coronary angioplasty and stent placement. He reported pain in his left lower leg, swelling, and warmth around his calf. He was admitted to the hospital for deep vein thrombosis. You are the day nurse and you are in for your assessment and notice that the patient's heart rate is 132 beats per minute, and he also reports shortness of breath and chest pain and a feeling of apprehension. He also tells you that he started to develop a cough during the night and forgot to mention it to the night nurse. His sputum is also blood tinged. What do you suspect is happening to George? So George has developed a pulmonary embolism, and this is when there's blockage of pulmonary arteries by a thrombus, fat, air embolus, or even tumor tissue. The clot will first gain access to the venous system and then the pulmonary circulation. The embolus travels with the blood flow, lodging in even smaller blood vessels, obstructing perfusion to the alveoli. The lower lobes of the lungs are commonly affected due to higher blood flow. PE is associated with a relatively high mortality rate, and up to 30% of patients will die if they are not treated. Accurate diagnosis and early anticoagulant therapy can reduce mortality rate. Most pulmonary embolisms originate from deep vein thrombosis in the deep veins of the leg. VTE, or venous thromboembolism, is the term used to describe the spectrum of pathology from DVT to pulmonary embolisms. Lethal pulmonary embolisms often originate in the femoral or iliac veins. So before we move on to the next question, I just wanted to go over some of the other sites or causes of pulmonary embolism. So other sites include the right side of the heart, especially for patients with atrial fibrillation, or pelvic veins. And this applies to patients who have recently given birth or they have had surgery. Upper extremity VTE are rare, but they can occur, and especially for patients who have central venous catheters or cardiac pacing wires. And if this is the case, sometimes removing these catheters can resolve this case. There are other times where thrombi in our deep veins can just dislodge spontaneously, or mechanical force is applied, so that means sudden standing or changes in blood flow rate. For example, if valsalvar maneuver is performed, this is one of the common triggers for dislodgement of a thrombi. What are the risk factors of developing a PE in the case of George? So the first is immobility or reduced mobility, and especially for seniors, right, whose mobility status may change, right? And the next is surgery, especially if you've had surgery in the past 3 months. And this is especially for patients who have had pelvic or lower extremity surgery, including hip and knee and joint replacements. History of DVT. Some other risk factors include cancer, obesity, hormone therapy, and this includes oral contraceptives, cigarette smoking, prolonged air travel, heart failure, pregnancy, and clotting disorders. Third question, what are some clinical manifestations of pulmonary embolism? So diagnosing PE is sometimes quite challenging due to diverse and non-specific symptoms. Additionally, a patient can have a gradual onset or a sudden onset. The classic triad of dyspnea, chest pain, and hemoptysis is present in around 20% of patients. You can expect sometimes mild to moderate hypoxemia with low PaCO2, and some other clinical manifestations include pleuritic chest pain, crackles, fever, sudden changes in mental status due to hypoxemia, and also accentuation of pulmonary heart sounds. And what this means is that, for these patients, sometimes you'll observe an increased heart rate. And the faster the heart rate, the faster the rise in ventricular pressure and the louder the S1. So when we're talking about a patient who has a pulmonary embolism, some of the telltale signs that just stands out from this case study is that his heart rate is elevated, he's having tachycardia, he's having shortness of breath, he's having chest pain, and he's just having that feeling that something is wrong, right? His sputum is also blood tinged, right? And he had a DVT, that's why he's in the hospital. He's had a previous surgery. So he's not only at high risk for developing a pulmonary embolism, but you're presented with a case that has all the telltale signs of a patient who will need further medical evaluation. What would be the test or assessment that you can do as the nurse? And these are stuff that you can do before the doctor comes to see the patient, right? So you can immediately take a set of vitals, place the patient on cardiac monitoring. If it is that your floor has that capability, you can auscultate his lung sounds and those heart sounds. You can also insert an IV, and while you're doing that, you would take some blood work. And we'll talk about some of the labs that you'll want to draw later on. What blood work might the physician order? That's the next question. So the doctor may order acid-base blood gas, and it can be either venous or arterial. George, in this case, is showing signs that he is having respiratory compromise. Other blood work include your CBC with white blood cell differential, as well as D-dimer levels and troponin level and BNP. Now, there are no blood tests that are really specific to pulmonary embolisms, but these do provide incredible insights into severity and alerts the physician that the patient may need further diagnostic testing. D-dimer level, it quantifies cross-linked fibrin fragments that present in circulation after clotting events like VTE, acute myocardial infarction, and acute stroke. It's rarely found in healthy individuals. The problem is, though, that it lacks sensitivity and specificity. So it does pose challenge. In fact, up to 50% of patients with small pulmonary embolisms exhibit normal D-dimer levels. However, elevated D-dimer levels coupled with a normal venous ultrasound may help the physician to know that this patient may need further evaluation, such as a lung scan or a CT scan. Elevated serum troponin levels predict an adverse prognosis, while BNP levels offers incredible insight as well into the clinical severity. A VBG blood sample was taken and sent. His results are back. Interpret the results below. We have a pH of 7.51, a PaCO2 of 30, a bicarb of 23, a PaO2 of 73. ABG analysis is very important. We're able to understand the patient's oxygenation and ventilation from these results. And in this case, the partial pressure of oxygen in the sample is low, it's 73. And it's probably low because of inadequate oxygenation secondary to occluded pulmonary vasculature, preventing matching of perfusion to ventilation. The pH is 7.51, which is higher than the higher normal limit of 7.45. So we have a pH that's quite basic or alkaline. And then we have a PaCO2 of 30, which is low, and a bicarb of 23, which is normal. Now, this tells us that there is no compensation going on from those kidneys. So we have uncompensated respiratory alkalosis, and this can occur when there is an increased respiratory rate leading to a decreased concentration of carbon dioxide in the blood. Now, since carbon dioxide is an acid, a decrease in its concentration levels results in increased blood pH, making it more alkaline. This patient is also experiencing hypoxemia. Which other member of the interdisciplinary team would you care to involve at this time? Now, always remember you are not in this alone. And so if you do have a patient who is deteriorating or there is a change in their status, you want to inform your charge nurse, you want to inform the attending physician, and in this case, I would call the respiratory therapist to come and do an assessment. And they'll let you know the best or most suitable supplemental oxygen administration that would help this patient and help them to have really good gas exchange. Which other tests may be ordered? Now, the tests that are displayed below, they're not diagnostic for pulmonary embolism, but they can give you insights about maybe concurrent problems that might be going on with the patient. For example, a chest x-ray may show abnormal findings such as atelectasis, pulmonary embolism, and then your ECG might show ST segment or T wave changes, and it might also show signs of tachycardia and right ventricular strain. What are the confirmatory diagnostic tests? Now, a pulmonary angiography is a specific and sensitive test for pulmonary embolism. However, it is invasive and it involves the insertion of a catheter through the antecubital or femoral vein, which advances to the pulmonary artery where contrast medium is injected. It allows for visualization of the pulmonary vascular system and location of the embolus. Spiral CT can also be ordered. However, I have rarely never seen this being ordered. And there may be that many facilities do not offer spiral CT scans. And you may also see a ventilation perfusion or VQ scan being ordered, but less frequently. The next question is, what drug treatments will be considered? Now, the first drug that may be considered is a fibrinolytic agent, such as tissue plasminogen activator, TPA, or alteplase. And these work to dissolve the pulmonary embolism as well as the source of the thrombus in the pelvis or deep leg veins, thereby decreasing the likelihood that the patient is going to have a recurrent emboli. Properly managing the patient's anticoagulant is cornerstone to effective prevention of further emboli. And most deaths are caused by recurrent pulmonary embolism. So we want to begin treatment immediately. The physician may also order unfractioned heparin IV infusion, and heparin works to prevent future clots. However, it does not dissolve existing clots. Unfractioned heparin IV is normally traditionally used. However, your enoxaparin, so your low molecular weight heparin, can also be used. Warfarin is initiated within the first 24 hours, and it's typically administered for about 3 to 6 months. There are some physicians who will adjust the treatment regimen to add factor XA inhibitors and direct thrombin inhibitors in the treatment of pulmonary embolisms. It is important to know that the dosage of heparin is adjusted according to the APTT, so your activated partial thromboplasmin time, and the dosage of warfarin is determined by your INR. There are oftentimes frequent changes and titration of the heparin doses initially in order to obtain a therapeutic APTT level. There are times, however, when anticoagulant therapy is contraindicated. So if a patient is having hepatic dysfunction causing alteration in their clotting mechanism, or they've had injury to their intestine, they're having overt bleeding, they have a history of hemorrhagic stroke or a neurological condition, as well as blood disorders or bleeding disorders, they will not qualify for anticoagulant therapy, and something else will need to be considered. As a primary nurse, it is your responsibility to know the adverse effects of these medications that you're administering and observe for them. Your nursing care should include assessing for complications of anticoagulant therapy, including bleeding, hematomas, and bruising. List other collaborative therapies. Now, this can include supplemental oxygen, and there are even times when the patient needs to be intubated and transferred to a higher level of care, such as an ICU. The patient will initially be placed on limited activity, so bed rest. You're going to want to ensure that there is adequate pain relief, so the physician may prescribe opioids for pain relief. Other collaborative therapies can include insertion of an inferior vena cava filter, and these types of filter are placed in the inferior vena cava, and they filter blood as blood is passed through the filter, and they work really well in preventing future pulmonary embolism. Another procedure that might be done is a pulmonary embolectomy. So a pulmonary embolectomy may be done in life-threatening situations, and this is where there is surgical removal of that pulmonary embolism, which is probably blocking an artery in the lungs. And patients who are experiencing pulmonary embolisms are often anxious, probably because of pain, difficulty breathing, fear of death, or just a sense of doom. Now, it's your role as a nurse to also explain to the patient the situation and provide emotional support and reassurance to help relieve their anxiety. What are some complications of pulmonary embolisms, and what should you monitor for? So the first complication that we're going to talk about is a pulmonary infarction. And this is where there is lung tissue death. Factors that do lead to occlusion of those large pulmonary vessels include insufficient collateral blood flow from bronchial circulation, or pre-existing lung disease. Now, if there is pulmonary infarction, it can lead to alveolar necrosis and hemorrhage. This necrotic tissue can then become infected, which can lead to abscess formation, and then the patient will have a concomitant pleural effusion. The next complication is pulmonary hypertension, and it can result from hypoxemia or involvement of more than 50% of the normal pulmonary bed. A single embolus event typically does not cause pulmonary hypertension unless it is massive. Recurrent emboli may contribute to the development of chronic pulmonary embolism. And this is a very important teaching when the patient is being discharged, that they are going to be really keeping an eye on their blood pressure and signs of pulmonary hypertension. Now, your discharge teaching for patients who are going home after they've been treated for having pulmonary embolism is going to focus on prevention, right? So, early ambulation, use of anticoagulant medication. It is important that you're stressing the important. Do not miss your blood work. Do not miss your medications. Make sure you're following up with your family doctor, right? And if it is that they are in the hospital, if it is that they are on bed rest, that we are applying sequential compression devices. And encouraging them that if it is that they do go home, that there are stockings that they can help if they're having circulation issues in their legs. So we've now come to the end of the video on pulmonary embolism. I really appreciated you sticking around and listening to this video on this case study on pulmonary embolism, and I do hope that you did find it enlightening. Thank you. Share this video with someone who you think may benefit. Remember to like, share, and subscribe. Until next time, thank you for joining Nursing Ed KGS Keaton here, signing out.